Zone Ads, World of Local Business Info.
Lights off. Lights off. So, respected founding members of TASLPACON ISAM, I thank you for giving me this opportunity. I'm really honored to be presenting on this topic in front of a lot of budding audiologists and seniors here. So the topic which I chose, and I felt like this could be slightly relevant to the upcoming audiologists. So recently we have seen that the special interest in vestibular sciences has been picking up, and traditionally this vestibular sciences has been a disputed area. We see many patients shuffling between ENTs, neurologists, audiologists. They come with a big set of files. Every possible investigation has been done, and none of them actually have a good result. So I've been associated with this gentleman last 1 year, and it was a wonderful journey with them. So just a small disclaimer I would like to tell, even though I will be speaking on a particular device, I have not received any financial benefits from them. Just because I'm using one particular product, my talk is based on that. I own this clinics. We have multiple branches. We have a hospital. And I'm very thankful to this great gentleman, Dr. Srinivas Dorsala. He's a renowned neuro-otologist. He's practicing in Bangalore. And I have been very fortunate to be receiving a short duration of training with Dr. Srinivas sir. And we started this balance and vertigo clinic in 2021, and it has been a 1 year. So this 1 year has been a very fantastic journey. Actually, I may not call myself as a neurotology specialist because I'm also still learning. And over the year, we have done around 100 BNG cases, and it was a very great journey. So traditionally, the descriptions of eye movements seen with BNG have been described in two routes. One is the ocular motor tests have been described and their abnormalities have been explained with enumeration of the causes. But with VNG, the approach has been changed. So we have a clinical diagnostic problem at one hand, and we see how VNG can contribute and collaborate to identify the actual problem. So what exactly is video nystagmography? If you are hearing this for the first time, so we all know photography, electrocardiography, ECG, electronystagmography. So graphy is nothing but just a writing, okay? With photo, when you write, it's a photograph. So what is an ECG? So with the electric potentials of the heart, when we write, it's an ECG. And similarly, electronystagmography. So based on this principle, with the movements of eye, we write a graph. That is nothing but video nystagmography. So what is the basic technique? The aim is to see the subject eye in complete darkness. So what we do is the subject wears a set of goggles. Then the goggles have an infrared camera. So they capture the video of the eyes. And there are special algorithms in the software which track the pupil. Okay, so let's assume this is eye. So the basic conventions of VNG is assuming the patient is seated right in front of you, and this is the right side and that is the left side. So eye has basically 3 degrees of rotation. See the pupil has moved to the right side. Okay. See, it just moved medial and it came back to the center point. So based on these degrees of movement, we obtain various graphs. Let us, I'll just give you a brief orientation how to interpret a VNG graph. So in this first movement, if you see, the eye has moved towards the right side. So in a VNG, there are only 2 possible movements. If the graph moves up, eye moves to the right, there's a positive. The red color, usually every VNG has a set of colors. In the VNG which we use, The red denotes the right eye and the green denotes the left eye. So any upward deflection of the curve means the right eye moves to the right and downward eye moves to the left. And whereas up and down movements, since there was no up and down movements, the green line is flat. So now if you can try to imagine how this, I'll repeat this again. See the movement. So the eye is moving to the right, came back to center, then came back to left, and again it has come back to the central position. So let's see how this graph is going to be on a VNG. See, it has moved to the right, the graph has gone up, then came back to midline, then came back to the left, it's going down, then came back to midline and came back to the median position. So now let's see the other possible movements. One is up and down. Okay, in VNG, the upward movement of eye is just upward graph, and it's very simple. The downward movement is down. So other possibilities here, the oblique movements, torsional movements. So in case of a torsional movements, you get both the graphs. So basically every VNG has various modalities where we test the eye movements, saccades. Saccades are nothing but rapid eye movements, then smooth pursuits, caloric testings, optokinetic movements, gaze testings, and positional maneuvers. So what are exactly are saccades? See, from center it has movement to right, and left, extreme left, right, extreme left, right, extreme left. So these are basically saccades. So this slide I'm going to show you how saccades can be impaired. These are various examples. See, the eye movements are not very rapid. It has just gone to one and stopped, and again it continued. So it's like a pendulum, jerky saccades. So every saccade gives you a possible diagnosis and which is going inside the brain. So I'll be putting few. Smooth pursuits. Imagine you are watching a tennis. The players playing. You follow the ball. You're standing in the road. The traffic flowing. This is how you track a car or an object. So imagine if your smooth pursuit is impaired. This is how you see, how you get a tracing in a VNG. Yeah, you can test. So optokinetic again. Gaze testing, basically we see all the four extremes. So I'm just skipping I'm directly going into how these are relevant to our basic clinical practice. Okay, the most usually patients who come to our clinics come with these following. Basically, we can classify into this 7 or 8 symptoms. One is mostly recurrent dizziness, vertigo, imbalance, immediately following something known or relatable triggers. And you have patients who come with complaints of, they say that my father has fallen down recently. And some people come with a predominant complaint of difficulty in walking, where they say they're swaying to one side. Then one more set of patients are who comes and says, I had 2-3 days back, I had a sudden vertigo. It was only one time, and there was no episode. Then again, there are few people who come and say, I have a recurrent vertigo which has been there for minutes to hours, and it subsides only after I take a prolonged rest. And there are few people who say they're always dizzy throughout the day, and so on. If you basically try to classify the symptoms, the most common presentation is usually vestibular migraine. So always keep in mind vestibular migraine. I'll just tell you 5 features if you want to evaluate. always ask five questions. Are you experiencing headaches, one side especially? Do you feel vertigo, spinning sensation? Do you have nausea? Not exactly vomiting, or kind of vomiting sensation. And most importantly, check for light photophobia. They have a very, they cannot see bright lights, and also they cannot tolerate loud sounds, phonophobia. And usually in clinical practice, almost 50% of the patients fall in vestibular migraine, and the next common is BPPV, benign positional vertigo, and which I'll be speaking more extensively in the following slides. And the third commonest cause being the Meniere's disease. So clinically, we should attempt to place the patient in one of those groups which I've told in the previous slide. Then you should consider differential diagnosis in each category. And this can be obtained with a combination of history taking, investigations, and also given a trial of various audiological evaluations. So we'll now proceed to see how VNG is guiding us in identifying these diseases. So first, let us see the most commonest and interesting disease. It's the BPPV. So usually the most commonly they say that I have vertigo episodes in one particular position. But not all positional tests can be, it's not possible to do all positional tests without, our regular tests are only based on few parameters. But with VNG, we can ask them, put the goggles on and ask them to demonstrate how they do it and how do they get the vertigo in their normal life. So we can try different provocative maneuvers, and we can clearly understand the nystagmus and the direction, and we can recognize the canals. So I felt this is one common maneuver you can do in any setting, the TASLPAC test. So I'll show you how this has been, how you can do it in your clinics. Sorry, this video is not pulling. Explain. So basically, keep the patient seated on a comfortable couch. Turn the patient's head to right side and briefly push her down. Her head should be hanging below the level of the table. And you should wait for at least 60 seconds. And since BPPV has a little latency, you may not immediately see the nystagmus. Sometimes you have to wait at least for 60 seconds, and then you can come back to the sitting position. So at least the TASLPAC test is mainly you can identify posterior canal BPPVs, and of course there are various tests which have been described by various authors, and each test has its own significance. So in this McLure-Pegmini test, the patient is comfortably seated again, and you put a nice pillow, and your head is placed 30 degrees to the bed, and you turn the patient to the lateral side. Once the patient is rolled over, you observe for any nystagmus. Then you bring back the patient to the supine position, and you observe for nystagmus. This test is usually, we do it to identify lateral canal BPPVs. Again, this one small test for identifying the rarest BPPV, which is the anterior canal BPPV. Here, it's a very simple test. Just from supine position, make the patient lie down, and her head should be hanging down. And in this kind of, the nystagmus is usually downweighting or upweighting. And the direction of nystagmus is usually, you have to It is in the relation of the patient's head. If it is towards his chin, it's downbeating, and if it's towards his forehead, it is upbeating, and it is not related to the doctor's direction. And I would like to skip these maneuvers. I think it will be a little boring for you. And a please maneuver is the maneuver which we commonly do for the correction of the right posterior canal BPPV. So I'll briefly play this video to see how this maneuver is done. The initial steps is same like the distal pipe. The patient is pushed down rapidly on towards the head on one side, and we keep this position for 1 minute. Then we slightly bring the patient to the midline position and turn towards the opposite side after around 30 seconds to 1 minute. Once the patient is turned 45 degrees to the other side, then we ask him to roll over, and we ask the patient to look down towards the floor, and then we slowly ask him to put his legs down and ask him to sit down. So here in this case it's a left side, and if you have a right side posterior canal, you will be doing on the right side. Sorry, opposite one. This is the right side. Traditionally, a lot of maneuvers have been described, and if you are really interested, you can go through all these maneuvers. A lot of these have been posted in YouTube. You can learn. Due to paucity of time, I am skipping this. I'll just briefly go through interesting tracings which we have seen in our clinics. So here, this is a patient having a right side lateral canal BPPV. So you can see how the BPPV is there. This is how you get the BNG tracings. If you notice, this is how you can, if you are experienced in BNG, just by looking at this graph, you can tell the diagnosis. And this bow forward for anterior canal BPPV. Notice it's always, so we see this, it's a upbeating or a downbeating is diagnosed. Sometimes there is also a torsional component. So left. So we have seen the right now. This is the left one. Big sulfide, the commonest. So the basic advantage is usually you can do it even without BNG. You can do it, but it's very difficult to the BPPV usually lasts for a few seconds. It's very difficult to trace and with the position. So BNG basically gives you a tracing and also a recording. There are few conditions where even a Valsalva can induce vertigo. I will describe you all the features, how, in what all conditions you get this kind of vertigos. And just a small test for, I hope you all know what is a vestibulo-ocular reflex is. Okay, so imagine you are walking at the side of a hall and you are looking at your watch, and if you want to turn towards suddenly, this is possible because the vestibular system and ocular system has a reflex, and so your eye is always fixated even though you are changing position like this. Imagine if this reflex is not maintained, you will lose contact. For a simple example, you are, as I said, you are watching in a stadium, you are watching a tennis ball. So you are following the tennis ball and also you are moving your head. So it's a very complex reflex, and a simple test with this is vestibular ocular reflex actually helps in differentiating peripheral vestibular disorders and central peripheral disorders. In central, usually it is impaired. Some small differential diagnosis. So, if usually patients come and say that they fell down and there was no loss of consciousness, and you can consider the following possible diagnosis. The first one is common, which is called the Tumarkin's autolytic crisis. Usually we see in late stages of Meniere's disease patients. They suddenly fall down without no warning symptoms, nothing. They suddenly fall down and they don't even realize that they have suddenly collapsed. And vestibular paroxysmia is something like a BPPV, it's sudden paroxysmal falls, and even BPPV related falls. And also keep in mind, most vestibular migraine patients experience this falls. So, when you get a patient with who say predominantly that they are not able to walk, so always consider the vestibulopathies. There is some kind of weakness, some kind of diseases in vestibular bilateral failures. It's very common. And proprioceptive loss is nothing but our dorsal columns in the spinal cord usually carry a lot of proprioceptive information to the vestibular system. Check for B12 deficiencies, and you all know cerebellar functions can also, dysfunctions can also cause a lot of walking imbalances, and any cerebral disorders, gait. Most importantly, if you work in a clinical setup, always look for orthostatic hypertension. Elderly patients are usually on a lot of cardiac medicines, BP, antihypertensives. So there is always because of mismatched dosages, the BP may fall once they suddenly wake up and they can have difficulty in walking. And last but the least, always rule out arrhythmias, any heart abnormalities. Then how do you identify bilateral vestibulopathy? A simple caloric testing. And in VNG, of course, the optokinetic testing gives us a clear-cut diagnosis. So when you have a first episode of prolonged vertigo, always think about these three possible. One, rule out stroke, then rule out the vestibular neuritis. Usually happens after a prolonged viral infection. Recently, post-COVID, we have seen a lot of vestibular neuritis. And always a particular stroke variant called the labyrinth, the blood supply to the labyrinth, the stroke of the labyrinthine area. And you can always classify vertigo based on the duration. If the recurrent vertigo is lasting from minutes to hours, initially we've seen seconds, which is the BPPV. Now if they say it's been minutes to hours, always again consider vestibular migraine. And again the rare condition called the Meniere's disease. Meniere's disease can present in various subtypes, like an atypical cochlear where the hearing loss first starts, and also the vestibular migraine, as I said. These following tests can actually differentiate these differential diagnosis, whether you have a spontaneous nystagmus with or without fixation. Just block the eye, and if there's nystagmus, you can identify. Then a frequent high frequency head shake can also induce nystagmus. Then you have patients who say complaint of chronic dizziness. Always consider triple PD, persistent positional perceptual dizziness. It is more of a clinical. Each topic is again a different presentation. It's difficult to explain every diagnosis at this juncture. If you are interested, you can learn about this. These are very interesting clinical scenarios. Again, recent onset. The previous ones are chronic. If you see recent onset, always think about autoimmune ear diseases and subacute medical conditions like partial strokes and all. For some rare clinical scenarios which we have come across, So supranuclear palsies, multiple system atrophies. Believe me, with simple VNG you can identify. You don't need to do a complex MRIs. You don't need to do anything. Just if any patient who comes with a vertigo with simple VNG, with every disease has its own characteristic VNG findings. Corticobasal syndromes, Parkinson's disease. So I just want to conclude. So basically, VNG is a recent development in the vestibular systems. If you are ready to invest, you can take one, and you have an instant pupil. You can record. These are very lightweight goggles. You don't have to use a mirror. Earlier, they used to use a lot of mirrors and bifocal glasses. And with one simple device, you can do ocular motor tests, vestibular tests, head impulse test, everything. Thank you. Most dizziness, every positional maneuvers actually provocate dizziness or vertigo.
So how an audiologist role is important in that, and how can an audiologist do that? Whether it is a hypotension or hypertension.
Yeah, I heard it. Just repeat for audience.
So prior to doing this video nystagmography, we need to check how the blood pressure is, whether it is a hypertension and hypotension. So it also differentiates the variation of the differential diagnosis. It depends on the diagnosis here.
Yeah, as I said, always see patients do not differentiate what is a dizziness and a vertigo. For them, everything is same. Unless you take a proper history, you will never identify what is actually telling. And most of the times, it is always orthostatic hypotension. So the elderly, they are usually on a lot of cardiac medicines, hypertensive medicines. So it's always better you do a simple blood pressure, one in the sitting position, one lying down. So if there's a variation of more than 20 systolic pressure, you can simply rule out, you can totally avoid the VNG.
And one more, most of they'll say that upbeating and downbeating nystagmuses are of central lesions or vascular lesions.
Yes.
How come it be BPPV also? So
BPPV you get in anterior, see, I hope you know the pairing, anterior canal, LARP we call, left anterior and right posterior, and right anterior and right posterior and left anterior. So whenever you have anterior canal, you get, not always the statement is actually false. There is always an overlap.
Even the diagonal positions also?
Yes.
So most of the bilateral vestibulopathies are like diagonal kind of things, the nystagmus?
No, it's not just the nystagmus always, okay? There are a big battery of tests in a VNG, and if you are not able to identify in a positional menu, you have to check in other, like optokinetic mechanisms, saccades. They all give you the clue for the diagnosis. Thank you.
Sir, it was an excellent presentation, sir. So in your clinical practice, so do you see monaural hearing loss along with vestibular system, a deficit or binaural loss?
So you see such cases in tumors like schwannomas, where it's cerebellopontine angle lesions. We see monaural hearing loss along with vestibular symptoms.
So if we found an SN, for example, mild or moderate loss, do we tell the patient to go for the hearing aid immediately?
No, we usually then suggest an MRI.
Okay.
We have to do an MRI and see what exactly. And also, you brought me an interesting question, topic. There is also, you have to check for aberrant arteries, sometimes vascular loops. Okay, a simple vascular loop can just form around a vestibular cochlear nerve where you have single side hearing loss and vestibular disturbance. So always there is a special MRI, it's called a 3D CIS. When you do it, it identifies the loop. I mean, again, here it's a clinical decision. See, the surgery is very complex and very expensive. If the patient is not really willing for a surgery, if they just want hearing, then you can go for a hearing aid.
Thank you, sir.
So I have one more interesting this one. people with normal eye and normal hearing, if they close eye and walk, for example, from here to that corridor, they cannot walk till that level. Most of them don't know this. And if can we use certain, means any normalcy is there, where it says like a symptom or pre-symptom for any other. Is there any studies related to that? Because visually impaired, they need definitely a stick. Right? So I have tested with my students also, third BScs earlier. I have asked them to walk from here to there, but interestingly, no one could walk. They are there, evident people here whom I have tried, and they could not walk. Normal eye and normal hearing, closing eyes, they could not walk full corridor. So, is there any studies related?
No, so basically the vestibular system is a complex reflex pathways where the vestibular system gets proprioception, takes a lot of input, proprioception, eye, hearing, as you said. So I'm not aware of any such test which has been done recently.
Very nice, sir. So just observation. Thank you very much. It's a wonderful presentation. We are fortunate to hear to you, and we all got some insights. Again, always it's a evolving topic, vestibular and balancing.
Excuse me, sir. Sorry to interrupt. Here.
So,
Hi, sir. I am Jyoti Das. Sir, my concern is like how you handle the children while doing the same. So, have you come across the same or any child with vestibular issues?
Yeah, that's a very valid question. We cannot do VNG if the kid is not cooperative. And pediatric vertigo patients are very, very rare. And only in my 100 series of cases, I could only do one kid. Luckily, he was cooperative.
Great, sir. What was the age criteria, and can you explain a bit about that patient?
There's no age criteria. The patient came from a distant place. The father said he's skipping school. He's saying he's complaining of vertigo. And unfortunately, VNG, every possible test came out negative. So we just labeled it as a psychological issue.
Great, sir. Thank you, sir. Thank you.
Subscribe to our channel, click the bell icon and select all.